Bismillah ar-Rahman ar-Rahim.
Rahim.
Welcome everyone in this new meeting of Egyptian Society of Nephrology and Transplantation CME chapter online meetings. I am welcoming all of you as usual in our usual time, Wednesday. And this day is 1 hour early, which is 9:30 p.m. Today, I am really honored and a pleasure to have one of my dear friends who is a genius in the field of critical care medicine and extracorporeal support in Cairo University and even worldwide. And he is one of the worldwide experts in the field of extracorporeal membrane oxygenation, ECMO. He is Professor Akram Abdelbary. My dear friend, Professor Akram is currently the Professor of Critical Care Medicine in Cairo University. And he is the director and the founder of ECMO unit in Qasr Al Aini, which is now known as the 4th unit of critical care medicine in Qasr Al Aini, the 4th of unit. Professor Akram is the past president of Southwest Asia and African chapter of Extracorporeal Life Support Organization. And as I said, he is one of the worldwide experts in the field of ECMO. And because of this, we are honored today to have him to speak about ECMO and combination of what we are interested in nephrology, CRRT, and ECMO as a session of critical care nephrology meetings. Before we start, I would like to thank our coordinator, Dr. Hazem Abu Shusha, consultant of nephrology in the Manhoor Medical Institute and the fellow of Egyptian Fellowship of Ministry of Health. Thank you, Dr. Hazem, for this work in this meeting and all of CME chapter meetings, and welcome to join the staff of this meeting. I will leave the floor to Professor Akram to start his session, and will come to you after the lecture for questions and answers. Please, Professor Akram, share your screen and start the...
هي مش شير؟
لا. انت عملت...
Thank you, Dr. Yasser, for this invitation. I am talking about the continuous renal replacement therapy in ECMO patients. First of all, I'll tell you about a brief about ECMO. What is ECMO? ECMO is one of the extracorporeal life support family systems, which involves the support, temporary support of the heart, the lungs, or both. It works through shifting part of the circulation outside the... It is a membrane lung, it's similar to the dialysis machine, kidney membrane. So this oxygenates the blood during the operation. You can see here that the gas exchange across the membrane according to concentration and pressure gradients. So the blood is actively oxygenated. We drain the blood with using a big cannula in the inferior vena cava. It is deoxygenated blood running inside the tube. Here you can see the pump. It's a centrifugal pump which drains the blood. So the pressure inside this tube is negative pressure. Then it's pushed from here by positive pressure to cross across the membrane, where it mingles with the oxygen coming from the wall. separated by the membrane, of course. So oxygenation occurs and decarboxylation, and then the oxygenated blood returns to the patient using another cannula, either in the vein or in the artery. So this is very important to understand how we incorporate the CRRT in an ECMO circuit. ECMO is used as a bridge for recovery in acute cases like acute H1N1 or COVID or similar diseases. And in transplantation, waiting for transplantation, or as a bridge to another bridge like LVAD therapy, permanent ventricular assist devices, or a bridge to nowhere in cases of ECPR. So it is temporary, partial, or complete organ support or replacement of the heart, the lungs, or both. And this depends on the configuration. What is the configuration? We have two main configurations. Either veno-venous support, where we drain the deoxygenated blood from the inferior vena cava using the pump and then crosses the membrane like here. The oxygenated blood returns back to the patient also in the venous compartment in front of the tricuspid valve, where it is distributed by the right side of the heart to the whole body. Then this works to replace the lungs and not the heart. We use the veno-venous ECMO only in patients who has normal heart function. If the heart is impaired, there is severe cardiomyopathy, we need a pump to maintain hemodynamics, then we use the ECMO as a pump, and of course, the blood is drained in the same way from the venous compartment using a pump, then crosses the membrane lung and is returned back into the femoral artery, where it shares in the cardiac output bypassing the heart and the lungs. So this mode is used for support of cardiac patients. The main issue is to shift back the anaerobic metabolism which happens due to decrease in oxygen delivery. The decrease of oxygen delivery occurs in cases of hypoxemia or in cases of severe myocardial depression. We're shifting back to aerobic metabolism through promoting oxygenation of the body and preventing tissue hypoxia. The hallmark of successful ECMO run is lactate washout, as lactate is the outcome from anaerobic metabolism and is washed out when the oxygenation is maintained using ECMO. Who needs ECMO? So we have veno-arterial ECMO to replace the heart in cases of cardiogenic shock due to either acute myocardial infarction, myocarditis, cardiac arrest, post-transplantation dysfunction, post-cardiotomy difficult weaning from the bypass, hypothermia with cardiac instability in arrhythmic storm, as a backup support for difficult interventions in septic cardiomyopathy and drug intoxication, like we do a lot of cases of aluminum phosphide or phosphine poisoning, acute postpartum or peripartum cardiomyopathy, trauma, and pulmonary embolism. In veno-venous ECMO, we use it to replace the lungs, especially in hypoxic patients where the PaO2 FiO2 ratio is below 0.8, despite lung protective strategy on mechanical ventilation. So we use ECMO when the mechanical ventilator fails to maintain oxygenation, or there is a steep rise in the CO2 levels. All this, of course, is maintained and happens in the intensive care. What is renal replacement therapy in ECMO? Acute kidney injury occurs in a lot of patients during ECMO. And this may be either to the original disease or to hemolysis on ECMO. And the indications are the usual indications for renal replacement therapy, but in addition to maintain fluid clearance And this can be achieved through promoting the circuit of incorporating the CRRT circuit either inside the patient's body or in the circuit, as we will show later. So this can be achieved through a separate access in the patient, and this is preferred, or via incorporating into the ECMO circuit, and I will show you how this happens. The advantage of having a separate access is to minimize circuit access and no high pressure alarms, because of course the flow of ECMO is very high, the pressures are variable, and there will be alarms. I will show you later. And the circuit advantage that you avoid mainly having an access in patients who has already receiving anticoagulation all the time. We have, of course, three main types of CRRT. We have continuous veno-venous hemofiltration, and this acts mainly like for fluid removal, or continuous veno-venous hemodialysis, which incorporates removal of small molecules, or continuous veno-venous hemodiafiltration, which works through removal of large molecules. And the CRRT, unlike dialysis, works by diffusion and convection. The dose of CRRT, usually recommended dose is 20 to 25 milliliter per kg per hour. We slightly increase the dose when we use the pre-pump diluent, but usually 25 is sufficient. And higher doses did not show any difference in survival in these patients. The flow rate, the blood flow rate, is usually in the range of 150 to 250 cc per minute. As I said before, and in Cairo University, we usually use separate access if it is feasible. If the patient is coming already in acute kidney injury before starting anticoagulation, we secure an access separate for dialysis. Usually this gives us ease of use even in high flow rates of ECMO. The only disadvantage is the puncture of the vessel during receival of anticoagulation. Or we can incorporate the ECMO, the CRRT, to the ECMO circuit. It's more cost effective, easy to set up, use of low blood volume, ease of operability, less resource intensive, avoid additional access, and the oxygenator can act as a bubble trap. As you can see here, we can incorporate the CRRT machine, the drainage from the venous line before the pump, or and return after the pump. So before the pump, and return after the pump. Similarly, we can drain after the pump. This is positive pressure, and return before the pump. This is negative pressure. This usually gives us less alarms, but in moderate flows, because the flow of ECMO is usually between 3 and 5 liters. Also, I want to say that it is very suitable for pediatric patients. We can incorporate the line before the oxygenator and the return after the oxygenator. In this case, both pressures are positive pressures. Or we can drain after the oxygenator and return before the pump, and we don't like this, because if there are any air bubbles, the pump will stop, and this may result in a life-threatening problem through interruption of the patient ECMO circuit. Sometimes we drain from post-pump and return pre-pump, and it's the same that this may interrupt the ECMO circuit. The disadvantages of CRRT to ECMO circuit incorporation is that if the CRRT machine venous line connected to the ECMO circuit before the centrifugal pump, purified blood from the CRRT returns to the negative pressure part. This generates low return pressure alarm in the CRRT machine, which may subsequently shut down the machine. So usually the CRRT is not always continuous and needs a restart every now and then. The connection of arterial line post-pump can trigger too high pressure to the arterial access side of the CRRT, generating alarms inside the CRRT machine. Connections with arterial line pre-pump and extracorporeal membrane oxygenation and CRRT venous line post-pump can trigger low pressure arterial or access alarms and high pressure return venous alarms in the CRRT circuit. And there is also another biological factor, which is that the difference in the flow and pressure will increase the shear stress on the blood, activating the clotting cascade and release noxious cytokines. This in turn can predispose to the potential life-threatening hemolysis, DIC, and enhanced systemic inflammation. So it's usually used for uremia, acidosis, electrolyte abnormalities, and fluid overload. The most frequently reported indications are fluid overload, prevention of fluid overload, and acute kidney injury with electrolyte disturbance. However, we always think about removing the extra volume in patients with lung injury and cardiac patients. So in ECMO patients, we want to sometimes remove the fluids to the dry weight. This increases the lung and heart recovery, enhances the heart and lung recovery, and may shorten the duration of ECMO run if used appropriately. The timing usually is the problem. The earlier, the better. So we don't wait because these patients are very sick and very fragile. So usually we start as soon as there is acute kidney injury or oliguria, or even fluid overload in absence of oliguria. Then maintain the patient on CRRT and ECMO as long as he needs. The mechanisms of acute kidney injury on ECMO happens in 70%, and 50% of patients need renal replacement therapy, and usually it's either to the original disease or secondary to the ECMO itself, where hemolysis occurs and inflammatory response resulting in a non-pulsatile flow, of course, resulting in acute kidney injury. In patients who receive CRRT on ECMO, the mortality is very high. Survival is 17%, up to 7, very low. And this may be related to either delayed timing of CRRT, or the severity of illness incorporating multi-organ dysfunction in ECMO patients, which have a very high mortality, almost certain. However, when these patients recover, the kidneys recover completely in most of patients and above 90% of patients in different studies, as mentioned. The CRRT incorporation also helps us to maintain nutrition and to maintain full doses of antibiotics, which are needed in septic patients on ECMO usually. And this is one of the advantages of using CRRT instead of intermittent hemodialysis. I'll show you one of our cases. This is a 25-year-old male with COVID. He had oxygen saturation of 70%, was intubated, mechanically ventilated, prone positioning, and this is his CT chest before intubation. You can see severe COVID lungs infiltration. ERDS. He was intubated and mechanically ventilated with refractory hypoxemia and PF ratio of 80 on assist control ventilation. prone positioning did not improve his condition. We calculated his REST score, which is probability of survival on ECMO, and was 3. And we used cytokine filters in CRRT, where for 4 days in this patient to wash out the cytokines with the cytokine storm. And this happened, this resulted in quick improvement of the lung condition, probably after the 3rd session of the 3rd day of CRRT. The patient was decannulated successfully, and we can see his CT remarkably improved after decannulation. Almost normal after 2 weeks, and discharged off oxygen therapy on room air. And he sent me his X-ray because he had some cough. He sent it in the opposite way, but I put it in the presentation like this to show you how this patient is leading a normal life. I'll show now a small video about our new ECMO unit in Cairo University. It was opened in the last year. It's 31st of December. This is a short video. I hope you enjoyed it. It's for 3 minutes, and then we'll have the questions and answers. Thank you very much.
Thank you, Professor Akram, for this simple talk for illustration of how to incorporate CRRT into the ECMO circuit, or how to use the both circuits together. And I think such a lecture should be very simple, not to avoid sophisticated things that cannot be illustrated. It is very simple and illustrative. And we can highlight the most important points during our discussion. For example, I have a question about how can you does incorporation of CRRT into the ECMO circuits affect your monitoring of oxygenation on the patient?
Thank you very much, but it does not affect monitoring because usually we monitor the patient himself, not the circuit, and that circuit is monitored automatically in some devices, not all devices. We monitor SpO2 saturation immediately before the oxygenator and after, so there is no interruption in this point. The blood is recirculating in the same way. Only if you are draining from the deoxygenated limb and returning back into the oxygenated limb after the oxygenator, which we avoid usually to avoid incorporation of air into the circuit, you don't have a problem with monitoring of oxygen therapy.
So you use the CRRT in the deoxygenated limb, not on the oxygenated limb at all. This is what I get. True?
Either we drain from the post-oxygenator, so you drain the oxygenated blood and return it back before the oxygenator, so it's oxygenated again, or you put it all before the oxygenator. And usually we avoid putting the return after the oxygenator. This is the key point.
This is the key point. Not to return after the oxygenator.
After the oxygenator, and not to put the return before the pump, because the pump is very sensitive. If any small air bubble, it will stop.
And this will cause interruption of
ECMO therapy.
ECMO circuit.
Yes.
Okay.
Centrifugal pump, Dr. Yes. It's a centrifugal pump, not roller pump like the CRRT or dialysis machines. It's a centrifugal pump, and it's magnetically levitated. It spins very quickly and it's very sensitive to any interruption by clots or air.
So you prefer the use of deoxygenated limb for insertion of the CRRT circuit, not to use at all, even for extraction from the oxygenate. You use only in Cairo University the deoxygenated limb for input and output. Or we
use sometimes it depends on the circuit. We don't like to interrupt the circuit. We don't like to cut the circuit to put the CRRT. So sometimes the connections force us to connect post oxygenator. If this happens, we connect the drainage post oxygenator and the return before the oxygen.
Return before the oxygenator. Okay. In CRRT, although we do not like to use it much and has many more complications, but what sometimes we use heparin-free circuits. Although it has many disadvantages, short duration, thrombocytopenia, etc., etc. Do you use some technique in ECMO, heparin-free technique, yes, or it is difficult to be done?
Yes. Many of ECMO patients are thrombocytopenic.
Yes.
This is the main disadvantage. Sometimes we need to do just heparin-free run. So if we are doing this only priming the CRRT circuit with heparin, and we use a dilution or pre-dialysis, the replacement fluid we use it before the filter with large volume. Then to avoid the quick consumption of the filters. But usually what happens is that we change the filter almost not more than 24 hours. It does not last more than 24 hours.
You are very lucky in CRRT. If lasted heparin-free 24 hours, this will be a great success Usually no more than
12, yeah,
12 hours maximum.
12.
No change of the dose of CRRT, you said, with application of ECMO, or you used a slightly increased dose.
Yes, we increase the dose a little bit if we are using the replacement mainly pre-dilution.
In
But
pre-dilution.
yeah, if post-dilution, we use the same dose for economic reasons, and then we monitor if we need to adjust, so we may adjust.
Okay. You speak about the calculated or actual dose?
Usually the calculated dose is less than the actual. So we just we calculate on 30, not 25.
Yes, we are CRRT calculate usually on 30 and to receive about 25, which is desired.
Yes, because the actual is usually 25. Yeah.
So you prescribe a higher dose than 30 to receive a higher than 25.
Because the actual dose is usually less than the calculated.
Okay. What I get is that veno-arterial is for cardiac support and veno-venous is for lung support. Can you explain for me, please, why this difference? Why veno-arterial for cardiac and veno-venous for lung support in ECMO?
Because venous ECMO, the return cannula is in the venous compartment. So the heart should be normal because the heart will pump the oxygenated blood to the body through the pulmonary artery to the left side of the heart. So if there's a problem with the heart, the oxygenated blood will recirculate again to the drainage limb in the right atrium. If there is a problem with the right side or the problem in the cardiomyopathy itself. So when we have a patient with cardiomyopathy or myocarditis or whatever disease in the heart or right ventricular pressure is high, then we put the patient on veno-arterial ECMO, where the return is directly into the arterial limb. Because
to avoid
the
backflow.
target, yes, always the return should be in the arterial limb.
Return in the arterial level to avoid backflow on the venous side.
Yes, we return the arterial limb to have oxygenated blood in the arterial tree. And this only in cases with cardiomyopathy. But in cases where the heart is normal and we need to oxygenate the patient, then we oxygenate him through the venous side.
The venous side. Okay. Application of, if we want to apply a sled, for example, or a usual machine of intermittent hemodialysis, the same principle is applied here?
Yes, we have already 2 intermittent machines in the ECMO unit. We use them usually in veno-venous cases, not veno-arterial. Because in the veno-arterial, the hemodynamics are very, very compromised. It's totally dependent on ECMO, and we don't want to increase much the ECMO flow, because increasing the ECMO flow too much in veno-arterial ECMO will deteriorate the cardiac function. So usually what we do in these cases is CRRT. So in veno-arterial, we always do CRRT. In veno-venous, we sometimes use the intermittent hemodialysis if the hemodynamics permit us. But if the patient is in septic shock or still in the initial phase, we use CRRT.
For the indication of CRRT. But you can use intermittent hemodialysis machine in veno-venous only. Part
in
of
veno-venous, but usually we do it very slow and we don't do much ultrafiltration because when the patient intravascular volume decreases a little bit, there is shattering on the cannula. The big cannula in the IVC collapse. The IVC collapses on the cannula and prevents ECMO flow, interrupting the patient's oxygenation. Well, if this happens and it's not possible to do the intermittent, we go for CRRT.
Okay. Thank you, Professor Akram.
Thank you very much, Dr. Yasser.
Thank you. Thank you for being with us and for this very interesting lecture.
Thank you very much.
Thank you very much. Thank you. And thank you for all attendees. Again, thank you, Dr. Hazim, our coordinator today, Hazim Aboushoucha. Thank you, Professor Akram, for this very interesting lecture and responding to all the questions in the discussion. And excuse me to close this session and meet you next Wednesday, inshallah, at the same time, 9:30. Please remember, 9:30 p.m. coming Wednesday, inshallah. Thank you, Professor Akram, and excuse me to close. تصبحوا على خير. السلام عليكم ورحمة الله وبركاته.